Good afternoon. Pleasure to be here with everyone. My name is Dr. Henry Ting. I'm a cardiologist from the Mayo Clinic on the Florida campus. I've been a practicing cardiologist for 20 years. My interests are in coronary artery disease, prevention, and interventional cardiology and revascularization. I'm here with my good colleague, Dr. Sabrina Phillips. I'll let her introduce herself.
Hello, welcome. We're glad you're here. I'm Sabrina Phillips, and I'm an adult congenital cardiologist here at the Florida campus. My interest beyond adult congenital heart disease includes maternal cardiology and imaging. So together today, we hope to talk to you guys about some of the advancements in cardiology in general and some specific advancements in our field.
And I also have an interest in health services research and education. I want to wish everyone happy National American Heart Month from the American Heart Association. And to introduce some topics which may be of interest to you, cardiology is a very innovative field. Sabrina and I are very grateful to be in this specialty. We've made major advances in diagnostics, particularly in imaging and making diagnosis non-invasively, as well as treating disease non-invasively. Examples include the electrophysiology lab, where we can now diagnose complex arrhythmias and treat and cure those arrhythmias, such as atrial fibrillation and ventricular tachycardia in non-invasive. In the field of coronary disease, we have additional new drug-eluting stents, which are now easier to place and very safe and require shorter durations of blood thinners after the procedure. And in the field of valvular heart disease, we're also becoming much more non-invasive in our approach for diagnosis and treatment, including using CT scans and MRI to image the heart, as well as using procedures such as transcutaneous aortic valve replacement or transcutaneous mitral valve repair to treat patients who previously heretofore would need cardiac surgery or open heart surgery for valvular heart disease. I'll turn it over to my colleague, Dr. Phillips, to describe some of the advances in congenital heart disease.
Thank you. So as Dr. Ting said, we are advancing on every front in cardiology using new technologies, and certainly that's the case in congenital heart disease as we expand imaging capabilities, making imaging of the heart faster, safer, and more accurate in terms of what we're able to see. We're also expanding our knowledge of the genetics of congenital heart disease, and we hope in the future that will allow us to treat differently some of the conditions that we're faced with. But I think all that being said, all the advances in technology, one of the best things about Mayo Clinic is not only taking that technology, but coming back to the basic human side, where we collaborate with our colleagues in imaging and interventional cardiology and our colleagues outside of cardiology to provide the best care for the patient. And then we try to take what we have learned clinically with the patients and advance the care based on just seeing how patients respond to different treatments. So it's not all technology, but that certainly does help us out. So I think we could turn to some questions now from the audience. The first question is, what is the latest in medical management of heart failure with preserved ejection fraction? So as a reminder, if you've not heard that term before, heart failure just means that the heart is inefficient in providing the needs of outflow to the body. So that inefficiency can cause because the heart is too stiff to fill appropriately without high pressures filling the heart, and that's what we would call heart failure with preserved ejection fraction. Or heart failure could be caused by valvular heart disease or by weakening of the heart muscle where it doesn't squeeze as well. But in this situation, heart failure with preserved ejection fraction, we've had some difficulty in maintaining or finding excellent treatments because currently there's no medical treatment specifically to cause the heart to relax better. But we do know, again, from good clinic-based research that exercise is one of the most important things that patients can do to improve their heart efficiency when they have preserved ejection fraction but a stiff ventricle. So I think the latest in management really involves understanding more of the lifestyle changes that we can make, but there are some advancements on the medical front that are coming, just not ready for current use.
Thank you, Sabrina. Looking at the second question, as mitral bypass is 22 years old, I'm just interested to hear the newest technology. So first of all, congratulations on being a survivor of cardiac bypass surgery. It's a major achievement. Um, Cardiac bypass surgery is meant to be a replacement of the coronary circulation and blood flow to the heart muscle, implanting new blood vessels such as vein grafts, as well as the intramammary artery or radial artery. It's meant to be a very durable procedure where patients can have long-standing, durable effects from and success from. With regards to a cardiac bypass surgery over 22 years ago, we still focus on the risk factors for prevention. So risk factors that cause blockages in your native coronary arteries as well as your bypass grafts include things like smoking, diabetes, high cholesterol, high blood pressure. So those are the things we seek to manage, because those are the things that we manage and mitigate. They prevent future blockages from occurring in those coronary bypass grafts. My recommendation to you is that you continue to follow up with your primary care physician and or cardiologist. If you are symptomatic, that's important to let us know so we can investigate further if the symptoms are attributable to decreased blood flow or circulation to your heart muscle. If you're not symptomatic, we usually would recommend a non-invasive stress test every 3 to 5 years after your bypass surgery.
Thank you. Next question, switching gears a little bit to the electrophysiology field. This patient says, I had a Watchman implanted 6 months ago and now considering AV node ablation and pacemaker for persistent AFib. The question is, will this stop the symptoms of AFib? Well, that's an excellent question. So the Watchman device, for those of you who might not have heard of that, is a device that's implanted inside the top chamber on the left heart, the left atrium. It closes off the left atrial appendage, which we think is one of the sources of blood clot when you're in AFib, so a source of stroke. And so we're hoping that Watchman implantation will lower the risk of stroke without the need of long-term blood thinner. Now, AV node ablation for atrial fibrillation is a procedure where we basically clip the wire where you connect your electricity from the top chamber to the bottom chamber. So you remain in atrial fibrillation, but the bottom chamber does not see all that chaotic electrical activity, and the pacemaker is implanted and paces you basically at a very steady heart rate. So most people do get rid of the symptoms of their AFib because the heart is no longer beating irregularly. Now, if your symptoms from AFib were more related to heart failure because you needed some mechanical squeeze from the top chamber of the heart, they may not completely relieve the symptoms to just have a regular heartbeat, but it can be.
Thank you. It's also about cardiac arrhythmias. The question is, I'm very interested as my heart is out of rhythm most of the time. Now, after inhalation, fixed it for nearly 10 years. That's an excellent question. I assume that the arrhythmia that you're referring to is atrial fibrillation, as Dr. Phillips just talked about. Epidemiologically, atrial fibrillation is a very common arrhythmia. In fact, amongst people over the age of 70, 1 in 4 have this rhythm all the time or intermittently and episodically. The normal rhythm is called normal sinus rhythm. Atrial fibrillation, occurring 1 in 4 amongst the elderly, is the most common second rhythm. And there are many ways we can treat atrial fibrillation, including medications, including ablation, which you had. And ablation is a very, very effective treatment for it, but long-term patients, including upwards of 25 to 30%, can have recurrent atrial fibrillation that occurs. In those circumstances, we really want to focus on what is the underlying causes for the atrial fibrillation that we might be able to change. And when we've studied this epidemiologically, we found that obesity, hypertension, and obstructive sleep apnea are the driving forces that cause the heart to go back from normal sinus rhythm to atrial fibrillation. So it's important for the patients to focus on those things, such as the obstructive sleep apnea, the high blood pressure, and obesity, which could be modified to prevent and mitigate future episodes of atrial fibrillation.
Thank you. That's a very comprehensive take on that. The next question, boy, someone knew me quite well with this one. The question is, are patients with tricuspid atresia eligible for heart and lung transplants? That's an excellent question. So tricuspid atresia is a complex form of congenital heart disease where the valve between the top and bottom chamber on the right does not form, so the bottom right pumping chamber does not form. This leaves the patient with a circulation that is really a single ventricle circulation, and most patients with tricuspid atresia are at least initially palliated with a procedure called Fontan, which is a way to get blue blood directed to the lung bed and then use your ventricle, the left ventricle, to pump the red blood to the body. So many patients do need some later work done with that after the Fontan, and patients are eligible for heart transplantation depending on several factors, including how many prior surgeries have you had, have you developed a lot of antibodies to other people's blood type, blood products that you've seen with prior surgeries. That can make transplant more tricky. Many patients with tricuspid atresia in the Fontan would not need a lung, but would just need the heart. But interestingly, they may also need a consideration for liver transplantation after the Fontan, as we know that liver cirrhosis is common. So this is one of the areas where we're really trying to expand our knowledge of heart disease for non-transplant treatments. So we're working very hard to understand how we can medically manage our patients with the Fontan better, what we can do with other electronic or medical devices like the ventricular assist device, how that could potentially be used. And we even have some protocols with stem cells currently right now, mainly for those people under age 18, but we're working on expanding all of these areas.
Thank you so much. That's very good. I learned something. Our next question is, which is a better indicator of cardiovascular disease, cholesterol quantity or quality, meaning particle size? This is an excellent question. I think as physicians and as patients, our goal is actually to prevent future sequelae adverse events, which is heart attack or death from having risk factors for heart disease. Cholesterol, be it the quantity or particle size or quality, is a surrogate marker for cardiovascular risk. So when you visit with your physician, I would encourage you to embark on calculating your cardiovascular risk using the and that tool will take into account your gender, your age, your cholesterol, as well as your blood pressure measurements, and look over the next 10-year horizon. What is your risk of experiencing a heart attack or death in the next 10 years? And someone who's low risk, meaning less than a 5% chance, may not need treatment with a statin, even if their cholesterol is moderately elevated. Whereas someone who's considered high risk, meaning your risk is as high as 8 to 10% over the next 10 years of having a heart attack or death, those are the patients who actually might need treatment with cholesterol medications, even if their cholesterol is normal. So I'm trying to not complicate the question even more, but I want you to focus on what is your overall cardiovascular risk, meaning everything about you and who you are, not just the cholesterol quantity or quality alone. We use a cholesterol most commonly as a surrogate marker, monitoring the efficacy of our treatments, and that's where the statins and treating cholesterol levels come into play.
Thank you. Well, we do have several people asking a similar question about patent foramen ovale, or PFO. Fix that or not to fix it? So the patent foramen ovale is a communication between the top two chambers of the heart, the atria. This is not a congenital heart defect, but actually a normal embryologic structure, meaning that every heart, as it's being developed, has a foramen ovale that is patent or allows blood communication between the two top chambers. The reason we have that when the heart is being developed is when you're in the uterus, you're not breathing air, of course, and your oxygen-rich blood is coming from your belly button, which is what's connected to mom's placenta. So we have to have a way for that oxygen-rich blood to come up from the veins that drain the body and go across into the circulation that's going to put that oxygen-rich blood to the brain. Now, 1 out of 3 people leave their foramen ovale open or patent their entire life. So 2 out of 3 people, that little communication closes at some point after birth. So it's been a big debate in cardiology. What's the significance of the patent foramen ovale, especially in terms of risk for stroke? The reason you could have a stroke from this is if you were to get a blood clot in a vein, that usually happens in your legs, a piece of that blood clot could break off, come up to the heart, and then since there's a connection from the right to the left heart there, the blood clot could move across that connection and get into the circulation that goes up to the brain. So we call that a paradoxical embolus, meaning it came from the venous side but then went to the arterial side. So it's very hard to get some clear-cut data, but I think over the last 3 years, we've really had some illumination with different studies. And the short answer to a long worded answer here is that if you've had a stroke and you have a PFO, and there's no other risk factors for stroke, meaning in general, you're under 60 years of age, you did not have hypertension, they did not find another cause of stroke, it can be beneficial to close the patent foramen ovale, and that closure can be accomplished with a device that's not surgical. We put it in through a catheter-based approach. But if you just are picked up to have a PFO, say you're getting an echo for something else, you've never had a stroke, you don't have to have closure just because it's found.
Mm-hmm. So most people with a PFO then don't need it closed.
Correct. The vast majority of patients don't need it closed. Only the small subset had a stroke, and thankfully that's not very common with patients with PFO.
Right, right. And I think a related question, Dr. Phillips, is the question, is a very small heart murmur anything to worry about? That's an excellent question, and I think for a cardiologist, I think we would start with taking a good history as well as doing a close, careful examination and listening with our stethoscope on the quality, severity of the murmur. If we think there's anything unusual about this heart murmur, we would then probably proceed with screening tests such as a 12-lead electrocardiogram as well as possibly an echocardiogram to further evaluate. Many people have innocent flow murmurs as blood flows through the heart. There are 4 cardiac valves, and there could be potential holes, just like Dr. Phillips described it. Patent foramen ovale is one of them. We would want to proceed with screening if we see any abnormalities in the history or examination and listening to the heart, as well as if there are any abnormalities on the 12-lead electrocardiogram, which again then cause us to want to do an echocardiogram or ultrasound. Dr. Phillips?
I think that's an excellent response to that. And I would just say that for parents out there who might be concerned that their child, someone's heard a murmur, the vast majority of children at some point during a regular well baby exam are going to hear the sound of blood moving. That's all a murmur is the sound of blood flow. And for the vast majority of those children, their heart's structurally normal and they're going to be fine. And pediatricians and pediatric cardiologists are well tuned into in these innocent murmurs, which is just the sound of blood flowing through the normal heart.
Right. And if you're concerned or if you are going to participate in high-risk activities such as competitive athletics, again, another reason to get a good, careful cardiovascular examination, particularly a 12-lead electrocardiogram. The next question is there a heart attack marker that is more sensitive and specific than troponins? As cardiologists, a heart attack means that cardiac heart muscle cell has died because it didn't get sufficient blood flow. So we have 3 coronary blood vessels, coronary arteries, that bring blood flow or oxygen to the heart muscle. And those can get blocked with atherosclerosis or cholesterol that limits blood flow. And if the blood flow is sufficient duration, then a patient can suffer what we call a heart attack, which translates to heart muscle cell death. The troponins are a very sensitive cardiac biomarker. The most sensitive ones are the high sensitive troponins. And they're very sensitive and specific at detecting ongoing cardiac muscle death at the time of the event. So if a heart attack is something that occurred weeks or months ago, we may not detect it on the troponin. The troponins are a blood test that we do when you're in the active phase of having a heart attack or having chest pain. Other modalities determine if you've had a prior heart attack in the past would be things like imaging that includes nuclear imaging, ultrasound echo imaging, or MRI imaging. If the troponin is equivocal, then there are other tests we can do during the active phase, including ultrasound and electrocardiogram serially over time.
Excellent. So the next question is regarding dilated cardiomyopathy, just some information on that and what we have available. So dilated cardiomyopathy is a weakness of the heart muscle. We're usually talking about the pumping chamber on the left or the left ventricle when that heart muscle does not squeeze as efficiently as it should, and the overall cavity size of that pump gets dilated. So there are many causes of dilated cardiomyopathy, and I think we are really starting to understand more and more what the underlying issue is, both genetically and how the genetics interact with the environment, including things like inflammatory risks. So we have made a lot of strides not only in understanding why you have dilated cardiomyopathy, but in terms of treatment, it's one of our most effective treatments in terms of medical management. So you may have an inefficient heart muscle, but medical therapy, which can be many pills to take potentially for a patient, but if you can stick with that regimen, let your physician and their team move up the dose as tolerated, some of the heart efficiency can improve and you can stay quite well on medical therapy. The good news is, as we're moving forward in understanding what to do with patients with dilated cardiomyopathy, that if you're not doing well on therapy, we are developing more and more what we call advanced heart failure technologies, including ventricular assist devices, and then even, of course, transplantation. But our goal would be to have no one need to go to transplantation or to limit that number.
Thank you. Our next question is, if a patient had coronary artery bypass graft surgery and he has chest pain, what is the best procedure you can get to diagnose the cause of this chest pain? It's an excellent question. The answer is a little more complex than a specific test. I think this is, again, where a good history and examination with a physician, a cardiologist, would be very, very helpful. If the pain is very, very similar to the prior chest pain that you've had before and the prior angina that you've had before, then your cardiologist may recommend that you go directly to diagnostic coronary angiography to evaluate the bypass grafts to see if any of them have become diseased. And especially if your chest pains are accelerating in terms of frequency or duration. If this pain is unlike your prior angina or coronary heart disease pain, then we might elect to do a stress test to determine with physical activity, by increasing your heart rate and blood pressure, do we, one, reproduce the pain, and do we see changes on your electrocardiogram, echo imaging, or nuclear imaging to suggest there's decreased blood flow to your heart with physical activities. Maybe I can take the next one as well.
Would be excellent.
It's sort of related to coronary disease. It says, what do you guys and gals think about statins? Well, I think statins are probably one of the most important tools cardiologists and physicians have in their armamentarium. We know that deaths from heart disease as well as myocardial infarction have declined significantly over the last 2 decades, and a large proportion of that decline can be attributed to statins and other things that lower blood pressure and control your diabetes factors. So statins are a wonderful tool to lower cholesterol and lower your risk of heart disease. We talked a little bit previously about the ACC cardiac risk tool. So if we did that tool and your risk of having a heart attack or death in the next 10 years was potentially 10% over the next 10 years, if we start you on a standard dose statin, we can lower that risk from 10% to about 8%, so about a 20% risk reduction. If we started you on a high-dose statin, we would lower that risk from 10% to 6% over that time period, so about a 40% relative risk reduction. Statins typically are very, very well tolerated. It's in the minority of patients, less than 5%, that have side effects and complications. The majority of them are fully reversible if we stop the drug. These things include having mental status changes, muscle aches, or liver function or abnormalities. Again, the great majority of our patients tolerate statins lifelong without issues.
And I would say now we seem to be opening up the realm of other drugs to treat cholesterol for patients. Either add on to your statin if you did not reach your goal. Say you have a genetic defect where you have very high cholesterol, and even on the highest dose statin, you're not there. We do have other receptors that we're targeting now with medical therapy that's available.
Right. They're the so-called PCSK9 inhibitors. A drug that's on the market is Repatha, and it's particularly for people who have a large burden of heart disease despite statins, or we can't tolerate statins. And they're very, very effective, and they're an alternative treatment to statins.
Excellent. So the next question is somewhat complicated, but it's about congenital heart disease. So what can be done if you're not approved for heart and lung transplant because you have severe pulmonary hypertension with transposition of the great arteries? So transposition of the great arteries is a complex form of congenital heart disease. They're actually really kind of two different circulations that we can envision with transposition of the great arteries. But sometimes patients, after their initial reparative options or their initial palliative treatments, do go on to need some form of advanced heart failure therapy. And so if patients have significant pulmonary hypertension, meaning that the blood pressure in the lungs is too high, that really does preclude heart transplant alone unless we can do something to lower those pulmonary pressures. In general terms, if you have high lung pressures and you need a heart transplant, you could be considered for heart-lung, but there's a lot of consideration that goes into that, and it's very individualized how we approach that therapy. So I think in general terms, the first thing we would do as a combined team approach with our transplant colleagues and myself is we would look for ways to try to reduce your lung pressures, whether that's with medication or whether we think there is a specific cause, like a valvular heart issue that's causing the lung pressures to be high, and we would explore what we could mitigate that. If all else fails, we would consider even more complicated procedures, potentially given the right situation with the patient, whether we could do certain types of biventricular assist devices or total artificial heart, which are, again, very complicated medical decisions based on very individualized factors. But the general answer is we would work hard to try to reduce your lung pressures and consider whether heart-lung would then be an option.
I think, as Dr. Phillips points out, this is a very complex diagnosis. It's something that Mayo Clinic is especially good at, meaning we work very closely with our lung specialists, our cardiac surgery specialists, our cardiac specialists as a team to take best care of the patient who have these multiple issues and complex issues going on.
Right. I think that's really, as we talked in the intro about the advancements in technology, which are fantastic in helping our patient, we don't want to forget the basic thing of we need to work as a team. It's certainly, we can't have an individual provider dealing with a very complicated situation like that. So that advances the science sometimes more than fancy technology.
So maybe the last question we can ask Dr. Phillips address as well, which is, given that this is Valentine's week, is a broken heart syndrome real?
It is real. So you can have a broken heart from emotional distress or other physical stressors, and we now understand that syndrome a bit more. It goes by a couple different names. One name is called Takotsubo cardiomyopathy, and other is stress-induced cardiomyopathy. So what this is usually a sudden onset of change in heart muscle function and efficiency, often involving sort of what we call the apex of the heart. If you think of the left ventricle, the pump, as like a football shape with one end cut off, we're down at the point when we're talking about the apex. That often becomes very dysfunctional, and maybe even the mid regions. And we think that it's because there's an increase in receptors to adrenaline in those areas, so that if you get very distressed, a spouse dies, or you have a scary event like a car accident, you can sort of flood those receptors with adrenaline, and the heart muscle says, whoa, I don't know what to do with all of this adrenaline. It's like your mom's yelling at you too much, so you just stop talking. The heart muscle just stops squeezing well. But the good news is it's not like a heart attack. The heart muscle does not die. It's simply just not responding at the moment. And once you sort of clear the stressor, and with time, the heart muscle will return pretty much to normal in function. So it's a real condition. Sometimes it does cause very serious situations where you can even have fluid back up into the lungs. You might need ICU care, but the good news is it's almost always recoverable.
That's great to hear that a broken heart will heal with time. So thank you everyone for listening in. I wish everyone a wonderful day.
Thank you.
Thank you for joining us today for this video Q&A. To find out more about future broadcasts, as well as share your experiences and find support from people like you, visit Mayo Clinic Connect at connect.mayoclinic.org. To request an appointment, visit mayoclinic.org.